Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
Hello, Amelia. It's nice to see you again.
Hi, Dr. Hughes. It's nice to see you too.
So you're here for a review of your blood pressure and to see how you're doing on the blood pressure medication we started at your last appointment.
Yes.
Is there anything else you'd like to talk about with me today?
Well, I'm still having pain in my knees.
I remember we briefly discussed that last time you were here. How often are you taking the ibuprofen now?
I was taking it mostly at night, but now sometimes I need it during the day if I've had a busy day at work.
Ibuprofen can affect blood pressure, so we should discuss some other options. A topical therapy may be better for you.
Okay.
And speaking of blood pressure, yours is 138/89 today, so it's lower than last time, but still higher than we'd like.
I've tried to eat less salt, but I'm also on the go a lot, so I usually have to grab whatever I can.
I understand. Have you had any trouble taking the new blood pressure medication?
No, I take it every morning, and it does seem like my cough has gone away.
Okay, that's good. Let's have a look at your recent blood tests. Your kidney function looks good, but your liver enzymes are a bit high. Previous results a few years ago were normal, so this is new. Do you have any history of liver issues?
No.
Okay. I also see that your hemoglobin A1C, which is one of the tests that we use to check for diabetes, is higher than before. It was below 6% and now it's 6.2%, so that means you're in the range of having pre-diabetes.
Yeah, my mom had diabetes. I assumed I would get it at some point too.
Well, genetics can play a role. Would it be all right if we talk about your weight today?
Yes, that's fine. I know people who are overweight can get diabetes and higher blood pressure.
Excess weight can contribute to many health conditions, including high blood pressure, diabetes, liver problems, and even knee or joint pain like you're experiencing. Is that something we can talk about today?
I've gained a lot of weight over the last few years. I can't seem to find a way to lose weight and keep it off. And I just feel so bad about myself.
Hello and welcome to this program titled The Patient with Obesity in Primary Care, Novel Strategies for Sustained Weight Loss and Better Health Outcomes. I'm Naveed Sattar, Professor and Honorary Consultant in Metabolic Medicine at the University of Glasgow in Glasgow, UK. So Amelia presented for a review of her raised blood pressure. She also reports ongoing knee pain, and we've seen from a recent blood test that she has slightly raised liver enzymes. Why is it so important to address excess weight in this patient? Obesity is a risk factor for multiple diseases. That includes diseases that are mechanical in nature, such as arthritis, metabolic in nature, such as type 2 diabetes and fatty liver disease, and potentially also mental health aspects. At the same time, we now know that intentional weight loss can improve type 2 diabetes and contribute to remission. It can help reduction in blood pressure, improve lipids, reduce fat levels in the liver. There are ongoing trials in patients living with long COVID, with osteoarthritis, with other aspects of fatty liver disease, sleep apnea, and also weight loss can actually improve symptoms in patients living with heart failure with preserved ejection fraction. And there is evidence that GLP-1 receptor agonists can also improve kidney outcomes in patients living with chronic kidney disease. We know that weight loss can rapidly improve metabolic factors such as lipids, liver fat, glucose, etc., potentially more slowly cardiac remodeling, and over time reduce atherosclerotic process. Therefore, given all of this evidence, it's essential to address weight in our patients. It's a conversation, however, that many of us shy away from. So what's the best way to talk about obesity with a patient? Is there any guidance? Well, there's the 5 A's of Obesity Counsel. It was originally developed for smoking cessation, but it's now recommended in clinical practice for obesity counselling. For example, by the Canadian Guidelines for the Management of Obesity in Adults. The 5 parts include asking permission, to discuss weight, assess the patient's story, advise on management, agree on goals, and to assist with the drivers and the barriers. And in terms of asking permission, what do the patients think? Well, in a trial of an opportunistic weight loss intervention versus simply advising the patient that their health would benefit from weight loss, less than 1% of patients thought that the intervention was inappropriate and unhelpful, whereas 81% thought it was appropriate and helpful. Many patients actually want to talk about their weight in a sympathetic and appropriate manner. The next step is to assess the patient's story. Goals that matter to the patient: obesity classification, check the BMI and waist circumference if appropriate, and think about the disease severity using a staging criteria that exists, such as the Edmonton Obesity Staging Criteria.
Losing weight is usually easier, but sustaining weight loss is really hard. Our bodies actually work against weight loss in some ways, and we tend to feel hungrier after we lose weight.
It just feels like it's all my fault. Like, if I was better at things, I wouldn't be this big.
It's not your fault. When did you start putting on weight?
I would say when my marriage was breaking down. I was so stressed, and I had to think about my girls and juggling work on my own. It was difficult to make ends meet. I didn't have time to cook properly, and I still don't. It's always hard.
You have a lot going on, and you're doing a great job. What we need to do today is think about how we can help you with your weight. As I mentioned, excess weight can contribute to many health problems like diabetes and high blood pressure, and losing some weight can improve those conditions and really impact your health. So it's important that we find a way to help manage your weight that works for you. What have you tried in the past?
Well, I've been on loads of diets. Last year, I joined a health club and went to some aerobics classes for a while, but my knees would often hurt afterwards. I also joined a class that focused on healthy eating, but with work and the family, I just couldn't go to the class every week. And I also found it embarrassing sometimes being in those classes.
Okay. Well, did you lose any weight with any of these interventions?
Yes, I did. Sometimes just a few kilograms, sometimes more, but then I just gained it back again every time after I stopped the classes.
That is so very common. How is your sleep?
Not great, honestly. I do tend to stay up late watching TV. It's my me time after the girls are asleep, and sometimes my mind is racing.
Well, if you're not getting enough sleep, that could be a factor in how your body's appetite is controlled. So that's something to think about. You need a good wind-down routine before bed, and you should be trying to get 8 hours of rest.
I do notice I will snack more at night if I stay up later.
I know you have tried some lifestyle changes in the past, but I would like to see if we can support you more consistently here. We have a wonderful dietitian who can help you with healthy options that work for your busy lifestyle. Would you like to give that a try?
I guess I can try again.
Let's make you an appointment with the dietitian, and I'll see you again in about 4 months to check how you're getting on. I will prescribe you a topical medication for your knee pain. I will also organize a liver scan just to check what's going on because of the results from your liver blood tests, but it's most likely this is linked to excess fat in the liver, which should fall if you're able to lose weight. Your blood pressure should also improve with weight loss, so we'll keep an eye on that as well.
Okay, thank you.
When we see Amelia again in 4 months' time, we should know whether she has had any success in losing weight with support from the dietitian. Weight loss from behavioural interventions typically peaks around 6 months, followed by gradual gain of weight in most individuals thereafter. If Amelia needs more support with weight management, what do we do next? Well, the 3 pillars of obesity management are psychological intervention, which focuses most on lifestyle and cognitive behavioural therapy, also attention to sleep, time and stress. There's pharmacological therapy, for which incretin therapy now is the major route used by most individuals. And of course, there's also bariatric surgery, which has got tremendous levels of evidence, although they don't have strong outcome evidence in the context of randomized trials. In Amelia's case, the next best step would be to start a GLP-1 receptor agonist, a class of drug that has multiple other effects in addition to weight loss. And Amelia has pre-diabetes, so a GLP-1 RA could help her blood sugar control. A test also suggests she likely has some excess fat in the liver. And in that context, it's of interest that semaglutide has been shown to have benefits in patients living with NASH, which is now called MASH, where we saw an improvement in ALT levels, but also an improvement in the numbers of the percentage of patients who had resolution of NASH, but without worsening of liver fibrosis. It's also relevant that we we now have evidence in the SELECT trial that semaglutide can also lower cardiovascular outcomes in people living with cardiovascular disease and with high BMI. Indeed, semaglutide compared to placebo lowered MACE by 20%, and there were nominally significant reductions in mortality, heart failure outcomes, and improved patient-reported health status, and also, interestingly, fewer serious adverse events than in placebo. The GLP-1s are just some of the options that are becoming available in this field. Tirzepatide is available. It's a combined GLP-1 receptor agonist, which gave excellent weight reductions of near up to 15% in people living with type 2 diabetes over to 72 weeks. Also, meaningfully improved glycemic control. In addition, it improved blood pressure by quite notable amounts and improved lipids. There are ongoing outcome trials with tirzepatide in patients with and without diabetes, looking at cardiovascular and other outcomes. And in addition, what is also exciting is there are many up-and-coming agents. So CagriSema, which is a combination of semaglutide plus cagrilintide, so it's a long-acting amylin analog. There's orforglipron, which is an oral non-peptide GLP-1 RA. Survodutide, which is a dual glucagon GLP-1 receptor agonist. And also retatrutide, which is a triple GIP glucagon and GLP-1 receptor agonist. And there are other additional compounds coming down the line. So now let's see how Amelia's been getting on with the lifestyle changes.
Hello again, Amelia. How are you today?
I honestly feel frustrated because my weight has not changed too much.
I see your blood pressure is a little better at 135/85 today, and you lost 2 kilograms.
I lost a little more at first, but then work was really busy the last few weeks, so I gained some back. This is what always happens. I had 2 consultations with a dietitian, and she helped me find healthier lunch ideas that I can pack for work, which is great. I've started eating breakfast, and I've been cutting back on snacks and sweet drinks. I've been doing exercise videos with my daughter. That has been really fun, although sometimes my knees hurt. But it just doesn't seem to be enough.
Well, those are all really positive changes. Well done.
Thank you.
I recognize, though, that despite your very best efforts, you may need some help to effectively manage your weight. There are medications available now that are safe and very effective for weight loss. Does that sound like something you might want to try?
It sounds great.
The main class of medication here is called a GLP-1 receptor agonist. GLP-1 receptor agonists. That's the class of medication.
Okay.
These therapies were first developed to help with diabetes, and they can also improve other weight-related health issues like high blood pressure and liver problems that are linked to excess liver fat, which your scan did indeed pick up. As you lose weight, liver fat, blood pressure, and your sugar level should all improve in parallel.
What do these medicines do to help me lose weight?
They work on receptors in the brain that help to control appetite. In a nutshell, they help you recognize when you're full, and that can help you to eat less. Most people who take them lose weight and also sustain weight loss more easily.
I see. That does sound like it would help me. Are there side effects?
There can be. Most GLP-1 receptor agonists are injectable therapies, so occasionally there can be some mild redness at the site where you inject. You just inject this once a week, though. A lot of people find they have some gastrointestinal adverse effects when starting these medications, some nausea, maybe some diarrhea or constipation. These effects are usually mild and worst when starting treatment. They tend to resolve with time. You also need to continue working on your diet, which will really help with reducing these effects. And we can make adjustments to the treatment if you experience any problems at all. It's a teeny tiny needle. I can show you how to use it now, and then we will schedule a follow-up appointment in 4 months. But don't hesitate to call if you have any questions or concerns in the meantime. We want to support you through this.
Thank you.
So when starting a GLP-1, what factors do we need to consider? Well, we need to anticipate adverse effects. These are mostly GI adverse effects, such as nausea or vomiting, diarrhea or constipation. And these are to be expected due to the mechanism of action of GLP-1 RAs. Importantly, these side effects are typically transient, mild to moderate in severity in the vast majority of individuals, and they mainly occur during initiation and up-titration of treatment. The management of GI side effects in clinical practice revolves around the 3 E's: education and explanation, escalation to an appropriate dose, and effective management of GI side effects. So in terms of education and explanation, we need to reassure patients that adverse effects are typically transient and tend to diminish with time. In terms of dietary and lifestyle guidance, we need to tell patients to reduce meal size, to be mindful to stop eating once full, to avoid eating when not hungry, and to avoid high-fat or spicy foods, particularly during the initial dose escalation period. We also need to tell them to moderate alcohol and fizzy drinks, and particularly in the context of this nausea and dyspepsia. And finally, we need to ask them to avoid lying down or undertaking intense exercise after meal. In terms of escalation to an appropriate dose, titration is actually the key. Start low and go slow, and tailor the doses to the patient's side effects, or continue the titration for longer than recommended at a low dose if the patient's side effects take longer to dissipate. Think about dose reduction in some individuals if the side effects become too severe. You can go back down a dose for a period of time before re-escalating. We also need to consider a differential diagnosis, because in some cases, the side effects may not be due to the GLP-1, but could be, for example, coexistent viral gastroenteritis, or perhaps another medication that they've started at the same time. We also can consider the short-term use of antiemetics or PPI if needed. And we mustn't forget about cholelithiasis or acute pancreatitis. Whenever patients lose weight, intentionally or unintentionally, we need to consider the potential for cholelithiasis. Finally, GLP-1 RAs are currently contraindicated in pregnancy and breastfeeding, so some form of contraception is recommended in women of childbearing age. Avoid these medications in patients with existing severe GI diseases, such as gastroparesis or inflammatory bowel disease. And that's because of their effects to slow gastric emptying, and therefore they may exacerbate GI symptoms. We need to avoid these drugs in patients with a history of pancreatitis. And finally, these drugs are contraindicated in those individuals with either personal or a familial history of medullary thyroid cancer, and the same for MEN2. So, I want to thank you for participating in this activity. So please continue on to answer the questions that follow and complete the evaluation. Thank you very much.